Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 376 of our pharmacotherapy series, which majors in fluid and electrolyte disorders. The first case reads, JOK, a 63-year-old man with renal insufficiency, was admitted to the hospital because of increasing weakness during the past several days. JOK began taking a magnesium aluminum hydroxide antacid several times daily 2 weeks ago when he exhibited stomach upset. Physical examination reveals hypotension and depressed deep tendon reflexes. The ECG reveals prolonged PR and QRS intervals. The serum magnesium concentration is 6.5 milliequivalents per deciliter. So my question to you is, what is the most likely cause of hypermagnesemia in JOK? Because the kidney is the primary route of magnesium elimination, renal impairment is a virtual requisite for hypermagnesemia. A common cause of hypermagnesemia is the use of magnesium-containing medications, such as antacids and laxatives, by patients with impaired renal function, including older adults. When a patient with renal failure, such as JOK, takes magnesium-containing medications, the serum magnesium concentration can increase substantially, resulting in toxicities. Hypermagnesemia may be seen when the creatinine clearance drops to less than 30 ml per minute. An inverse relationship is observed between the serum magnesium concentrations and the creatinine clearances. Hypermagnesemia is also seen in patients with acute renal failure during the oliguric phase, but not the diuretic phase. Other potential causes of hypermagnesemia include adrenal insufficiency, hypothyroidism, lithium, magnesium citrate used as a cathartic for drug overdose, and parenteral magnesium given for preeclampsia. I would now like you to describe the usual clinical presentation of a patient with hypermagnesemia. An elevated magnesium serum concentration alters the normal function of the neurologic, neuromuscular, and cardiovascular systems. When the serum magnesium concentration is greater than 4 milliequivalents per liter, deep tendon reflexes are depressed. They're usually lost at greater than 6 milliequivalents per liter. Flaccid quadriplegia can develop when the concentration is greater than 8 to 10 milliequivalents per liter. Respiratory paralysis, hypotension, and difficulty in talking and swallowing may also be present. Changes in the ECG may include a prolonged PR interval and widening of the QRS complex. Complete heart block may be seen at concentrations of approximately 15 milliequivalents per liter. In mild hypermagnesemia, the patient may experience nausea and vomiting. Drowsiness, lethargy, diaphoresis, and altered consciousness may be present at higher serum magnesium concentrations. JOK's increasing weakness, hypotension, depressed deep tendon reflexes, and ECG findings are consistent with hypermagnesemia. The next question reads, how should JOK's hypermagnesemia be treated? If magnesium-containing medications are discontinued in patients with hypermagnesemia, the serum magnesium concentration will usually return to the normal range through renal elimination. When potentially life-threatening complications are present, as in JOK, 5 to 10 milliequivalents of IV calcium should be administered to antagonize the respiratory and cardiac manifestations of magnesium. The dose of the calcium can be repeated as necessary because its effect is short-lived. In patients with good renal function without life-threatening complications, IV furosemide, plus 0.45% sodium chloride to replace lost urine volume, will enhance urinary magnesium excretion while preventing volume depletion. Hemodialysis or peritoneal dialysis is indicated for patients with significant renal function impairment and possibly for those with severe hypermagnesemia. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 377.